Sinus rhythm originates from the sinus node, located at the junction of the right atrium and superior vena cava. Normal sinus rate ranges from 60 to 100 beats per minute. A normal sinus P wave is positive in leads II, Roman 3, and AVF. It is biphasic in V1 and negative in AVR. Physiologic sinus tachycardia occurs when heart rate exceeds 100 beats per minute due to sympathetic stimulation. Common triggers include exercise, fever, pain, and pregnancy. Physiologic sinus tachycardia shows gradual onset and gradual offset. This helps distinguish it from atrial tachycardia, which has abrupt onset. Inappropriate sinus tachycardia is a non-physiologic form with elevated resting sinus rate out of proportion to activity. It is more common in women in the 3rd to 4th decade. Patients with inappropriate sinus tachycardia present with palpitations, dizziness, fatigue, and chest discomfort. Mechanism involves autonomic dysregulation of sinus node automaticity. Postural orthostatic tachycardia syndrome causes a heart rate increase greater than 30 beats per minute, or above 120 beats per minute within 10 minutes of standing. POTS is associated with autonomic dysfunction, often following viral illness. Management includes volume expansion, conditioning, and vasoconstrictor support. Common causes of sinus tachycardia include fever, anemia, anxiety, dehydration, infection, pulmonary embolism, myocardial infarction, and thyroid disease. Drug-induced sinus tachycardia may occur with epinephrine, dobutamine, salbutamol, caffeine, amphetamines, cocaine, and alcohol. Withdrawal of the agent is essential. Focal atrial tachycardia arises from abnormal atrial foci due to automaticity, triggered activity, or micro-reentry. It may be sustained or incessant. Electrocardiogram shows abnormal P-wave morphology in atrial tachycardia compared to sinus rhythm. Warm-up and cool-down behavior is a key diagnostic clue. Adenosine may terminate atrial tachycardia in cases of triggered activity. However, AV nodal blockers often only slow ventricular response. Hemodynamic instability or refractory atrial tachycardia requires synchronized cardioversion. Stable patients are managed medically or with ablation. Long-term management includes beta blockers, calcium channel blockers, or antiarrhythmics such as flecainide, propafenone, or amiodarone. Catheter ablation is highly effective for symptomatic or incessant atrial tachycardia, with success rates above 80%. Focal atrial tachycardia may act as a precursor to atrial fibrillation or flutter. Stroke risk is lower than atrial fibrillation. In summary, sinus tachycardia is physiologic or pathologic, depending on context and mechanism. Accurate differentiation from atrial tachycardia guides appropriate therapy.